more. All right, so welcome everybody. This is really exciting. So glad to have everyone here. This is our first webinar that we've had. We are so thankful to have Dr. Sandy here. So before we do get started, just to go over, as you can see, some Zoom instructions. So first and foremost, just because background noise, we have it. We have kids, we have dogs. I know mine are loud. But so if you can, everybody's doing a great job so far. Mute your I can't even talk. Mute your microphone. And then at the end, if there is time, we are going to be asking questions. So if you do have questions, put them in the chat box. Myself, Jody, Ryan, we are going to be asking Dr. Sandy questions just because it can get a little cumbersome if everybody's, unmuting. So we are going to try to gather all of those questions and ask them. We are going to ask them throughout the webinar, kind of at the end of certain sections, and then we are going to do it at the end as well. We may not get to all of the questions, but we are writing them all down, and we are going to we're going to get the answers, and we will be sending something out after the webinar. The other piece here is confidentiality. So this is being recorded. So please don't share any financial information, personal information. Our goal is that this is something that we are able to share with the community. So hopefully we're going to have this up on our website in the next 1 to 2 weeks. So again, confidentiality, don't share your personal stuff. And then, basically I just said that we're gonna share this, and we're gonna do our best to answer the questions and then get those answers to you. So from there, this is me ending my share. I'm gonna stop that and I'm going to pass it on to Dr. Sandy.
Okay, can everybody see this and hear me? Can you guys hear me?
Yes, we can. I'm sorry. Sorry.
That's all right. Hi, everyone. I'm Sandy Van Calcar from Oregon Health and Science University in Portland, Oregon. I've been interested in galactosemia really since some of my very first days in metabolism. I had a very interactive mom who had a lot of questions. So I just started looking things up and really kind of became attached to this disorder. So what I'd like to do today is talk about diet treatment and bone health. So just to get everybody on the same page, just to review galactose metabolism, I'm sure you've gotten this info in your clinic, but can you guys see my arrow or no? Right here.
Yes.
You can. Oh, great. Okay. So galactose metabolism is we're restricting lactose, which is galactose and glucose. What breaks that down is lactase, which is an enzyme in the GI tract that releases galactose, which is then converted to galactose 1-phosphate, and then to glucose 1-phosphate and something called UDP galactose. It's this enzyme right here that converts galactose 1-phosphate to glucose 1-phosphate and UDP galactose that is deficient in classical galactosemia. And this enzyme is galactose 1-phosphate uridyl transferase. So what happens in someone with classical galactosemia and a deficiency of that enzyme is both galactose and galactose 1-phosphate will build up in the bloodstream. There will also be an attempt by the body to get rid of that excess galactose any way it can. So other metabolites, such as galactitol, galactonate, will also build up. but it's really this galactose 1-phosphate that is producing a lot of the problems that you do see in classical galactosemia. So this is the infant presentation. If you think back to when you or your child was a baby, typically they're normal at birth, but then will stop feeding as well, might start vomiting, lethargy, so not easy to wake up. Then that can develop into liver dysfunction, jaundice. If we're not starting treatment, then you can have renal, cerebral involvement, cataracts. And again, if this disorder is not treated, then a baby may develop sepsis and can pass away from this disorder. Fortunately, newborn screening has definitely reduced the severity of this initial presentation. And the treatment is to start a diet, which is lactose and galactose restricted. Even though we start this diet as soon as we possibly can, classical galactosemia is a disorder that does have some long-term complications that can develop in some children. And so I list some of those here. So some kids have problems with growth, ovarian dysfunctions, very prevalent in females, speech abnormalities, learning disabilities, low bone density. And really the pathology is not completely understood why we are seeing these long-term complications. There's many theories and a lot of research going on, but at this point we really can't pinpoint something that is causing these complications. One thing I do want to point out is something called endogenous galactose production. You might have heard this from your clinic team. And what I wanted to explain what it was, because it's kind of misunderstood, I think, by a lot of people. So endogenous galactose production, it's not like the body is producing galactose. So the body can't produce galactose. The only place it can get it really is, again, from this lactose down here. So really, I think the better way to think of it is endogenous galactose turnover. So you have, I'm calling them glycoconjugates, that's proteins, lipids in cell membranes, other parts of the body that have a galactose that's hooked onto it. And what's happening with this endogenous galactose turnover is these products here are breaking apart. That puts the galactose back into the bloodstream, and that can produce more galactose 1-phosphate. So again, it's not like we're producing it. It's coming from this breakdown of all the different components in the body that contain galactose. Kids will have different degrees of this endogenous galactose turnover, and oftentimes that is something that your clinic might refer to. So this endogenous galactose production, galactose turnover, we figured this out in the 1990s. And when these studies came out, it really kind of changed the way we thought about diet treatment for galactosemia. So up to that point, we were being very cautious with everything that contains galactose, which includes a lot of plant products. And so we were, again, restricting things that we aren't right now. And this is just kind of illustrates what we're talking about. So this typical diet, this is the amount of galactose. So we're talking 12,000 milligrams per day. This is somebody who's drinking milk. The galactosemia diet is about 50 to 100 milligrams of galactose. And then we're looking at this endogenous production, this endogenous turnover, which can be about 1,000 milligrams in an adult. So if you compare these two, this galactosemia diet, which has, again, this was when we were restricting fruits and veggies and legumes, etc. This is so small compared to what is being turned over in the body that we started to question, well, why are we restricting some of these foods that contain galactose, but not nearly as much as you would see with the dairy products? So this is what we were doing before the year 2000, or yeah, 2000. Gosh, that was a long time ago. Anyway, we were eliminating basically all dairy products. Anything made from dairy that was excluded. We were eliminating organ meats. I'll talk a little bit more about that. And then we were also eliminating plant products that had a higher galactose content. And those are listed here. There were several fruits and veggies and legumes that we were restricting. And this is the same list, but I've crossed out the things that we are no longer restricting. So you can see we are now not eliminating any plant products. We've allowed several dairy products. And the way we did this is we did studies measuring the galactose content of different foods. And when something might have had some galactose, but a very small amount, that told us that we really don't need to be restricting that food. So I just want to explain a few of these concepts here. So a lot of the plant products we are now allowing, and hopefully that's what you got from your clinic. I'm hearing that there's still some things out on the internet about restricting plant products. But where you find galactose in plants is, so this is a plant cell. And you might hear the term free galactose. That's galactose that tends to be inside the cell. This can be digested. It can enter your child's bloodstream. And then there's also galactose in what we call the cell wall, which is the outside here. This we call bound galactose. That is, in general, not available for digestion in the human GI tract. So that's the difference between those two words. The free galactose amount in these different foods can be increased as plants ripen. Most processing, so canning, cooking, heating, etc., can release more galactose from plant products. And really the biggest one is the fermentation process that can really release a lot of galactose that is found in plants. But even though there is galactose in plants, the amount is very small, minuscule, compared to, hold on here, I lost my screen. There. Very minuscule compared to dairy products. So there's about 600 milligrams of galactose in just 25 mils of milk. That's about an ounce. To get 600 milligrams of galactose, you'd have to eat 2.5 kilograms of tomatoes. This was something that we used to restrict. 7.5 kilograms of apples. 12 kilograms of peas. So again, if you're thinking comparing to milk, these foods that come from plants yes, they can have galactose, but it's very minor compared to the amounts that you would get from the dairy products, which we are most concerned about in the galactosemia diet. Another one that I think is really confusing is legumes. So this would be things like garbanzo beans, kidney beans, chickpeas, etc. These are, again, allowed in the galactosemia diet. If you want to know where that galactose goes, a lot of it ends up in the cooking liquid. So if you're very concerned about getting galactose from legumes, you can honestly just throw out the cooking liquid or throw out the liquid that's in the can with the canned legumes, and that would remove almost all of it. The products that tend to have the most galactose in this group are the soy products that are fermented. So I list those here. So there's soy sauce, miso, sufu, tempeh. These definitely do have more galactose than any of these other soy products that are shown in this diagram. But you need to consider the amount that you and your child are eating. And if you think about, let's just take soy sauce, for example, really you're not drinking soy sauce, or at least most people aren't, and you're adding it to foods. Really, there's like about 45 milligrams of galactose per tablespoon, like 18 milligrams in one of those packets that you get from the Chinese restaurant. So really, it's very low. And so what we're saying with these fermented products is just be aware that there's more galactose in them, and just, not overdo it in your diet. And honestly, for older individuals, rather than infants, young children, I honestly say don't even worry about this at all. As you get older, we can liberalize the diet even more than what we have already liberalized it for all age groups. Also, we have allowed some dairy products in. So this just shows you the curds and whey that you get when you take milk and you're making cheese, where almost all the lactose goes is in the whey part. And so we still restrict whey proteins and other milk products that come from whey. But we have and are now allowing a lot of different products that come from that curds portion. And so this is the casein part of the milk when you're making cheese, and also caseinates. So we analyzed a whole bunch of different cheeses, and we found that a lot of them have zero galactose. Some of them have a small amount of galactose, like less than 50 milligrams. And these are the ones that we're now allowing in the diet. So what are the factors that are affecting the galactose content of cheese? Different cheeses use different cultures to make the cheese, and just the different cultures can make a difference in the amount of galactose. There's different processing steps to separate curds and whey for different cheeses that can have an impact. But probably the biggest one is the time that that cheese is aged. And that means just that the cheese is sitting around ripening, getting ready to eat. And it's that aging process that can take the lactose that are in some cheeses and actually over time break that the lactose down. So this is a list of the allowed cheeses. And Emmentaler cheese is Swiss cheese here in the US and Canada. So those are equivalent. Those are allowed. Recently, there's been some new analysis out of the group from England. Baby Bell cheese, the one that's in the red wax, that one has very little galactose. It has some, but not enough for us to get too worried about. And so this is one that you can give to your child. It tends to be milder tasting than a lot of these cheeses up here. And so it's been a good addition to the diet. I will send, I'm hoping that this can be put out on the Galactosemia Foundation website. This lists allowed cheeses and then cheeses that are not allowed. I need to add Baby Bell, but I think it's a really nice handout that was produced by Boston Children's Hospital. Another food that is made from that curd part of milk are the caseinates. This is used as an additive for a lot of different types of foods. Again, our concern was that residual lactose, which would mean residual galactose. But when you actually measure it, 100 grams of caseinates only has about 35 milligrams of galactose. So again, the amount that's used in foods as an additive is very small. So again, there might be a couple milligrams of galactose in there, but you do not need to restrict this in the diet. So if you're seeing it on food labels, sodium caseinate, calcium caseinate, you can go ahead and eat that or give it to your child to eat. I like this list, and again, I'm hoping Galactosemia Foundation can put it on the website. This came from the international guidelines that came out in 2017. It lists the foods that are okay to eat. It lists the foods and ingredients that are not okay. And then it has this middle part here, this used in moderation. These are like that soy sauce, soy products that are fermented, again, has more galactose. But again, if you're eating it in moderation, it's not too much. Offal is liver and other organ meats. Again, if you're not eating it every day, and honestly, I haven't had any patient who has gotten all excited about the fact they can eat liver. But again, it has galactose, but not enough to get excited about. Meat byproducts, those are things that can be found in like sausages and hot dogs. But again, it's not enough that you can't have those foods in the diet. You just kind of need to be aware that there is some galactose in that. Again, for older individuals, I would not worry about these foods used in moderation at all. I would just go ahead and include them in the diet. Why don't I stop there and see if there's any questions regarding the diet? I'm happy to answer at least a few of them before we go on.
We have lots of questions. All right, so the first one, so my son is 25. Do the same guidelines apply for young adults, or can we relax them? And I think that you kind of answered this one already.
Yeah, so you can relax the diet. Definitely those foods that are in that moderation category, don't worry about them at all. Even if your child is eating something that might have some whey in the ingredient list, it's still probably okay for older individuals. Just staying away from the big ticket items. So, the milk and the cheeses that are not on the allowed list. Some of the, again, big ticket dairy items I would still restrict. But, you can definitely loosen up on some of the things that are just like on a component of foods and listed farther down on the ingredient list of that food.
So this one, so oftentimes there aren't many dairy-free choices for children in restaurants. Chicken tenders tend to come a common offering, what is the thought process on allowing foods possibly containing dairy, like breaded chicken tenders, rolls, buns that may contain it?
Mhm. Um, I would say do the best you can. Don't be concerned about asking, the waiter, hey, can you check with your, the people that are cooking this? Does this have dairy products? Again, I think if you're staying away from those big ticket items that are obviously dairy and you're going out for a restaurant, it's a special night or something like that, or even if you're traveling, um, yeah, there's likely some dairy in some of those foods, but I think you're fine not getting, too excited, too worried about it, and just enjoy yourself at the restaurant.
Uh, is there an amount, a limit on aged cheeses, or should they be eaten in moderation?
No, any of those cheeses that are listed on that OK list, you don't need to be worried about the amounts. Most of them have like 0 milligrams of galactose in there. So the amounts do not matter.
I don't know if are we getting into label reading at all? The,
I didn't put that in there. Um, the if there's a question about that, um, I will. There's a lot of kind of rules for looking at labels, so no, I did not put that in there. Um, if there's questions about that, please let me know. I can also send a copy of like a handout that we use with our patients about label reading. Um,
I think you'll
so
be able to answer this one. I mean, I think you'll be able to answer any of them, but if something says contains milk, but the only ingredient in the label is natural flavor, would it be safe?
yes. So um, the here, at least here in the US, very tight restrictions on what you say may contain dairy because of the big concern with people that are allergic to dairy products who might have, an anaphylaxis reaction. And so what the companies do is they say they might label it as may contain dairy products because it's produced in a plant that does manufacture products with dairy. But for our purposes, if you're reading the label and there isn't anything that's a dairy product on that list, then it's fine for kids with galactosemia. Again, it's put there that may contain dairy as a really caution for those that are allergic to dairy, which again is not our group. So again, go by what's on the ingredient list rather than that warning.
And I think we'll do one more and then we'll save some more of the diet for the end. But I guess this will kind of be a two-part. So someone mentioned, and I think you did kind of answer it, but they were unclear about hot dogs and sausage. What exactly are they looking out for? And then somebody also pre-webinar asked about mechanically separated, and is that okay?
Okay, so mechanically separated, I'm not sure what exactly what that means, but really, if there isn't an ingredient that's not allowed on whatever food is mechanically separated, then I would not worry about that. Um, as far as like sausages and things, um, again, that meat byproducts, if you read the label, you might see meat byproducts. That means that it's possible that they might have used some organ meats in the production of that sausage or hot dog. Um, again, we put this in the moderation list, especially if you have an older child, I would not worry about it. Uh, if you're seeing meat byproducts, wouldn't worry about it. Younger kids, read the label, try and be cautious when you do see that on the label. Um, And again, it's more of a caution that it's always going to have galactose, but it does increase the chance that that food would have galactose. Hope that answers that.
It does.
Okay, good.
Okay. All right.
Okay, so I'll go ahead here. Hope we should be able to get to some other questions as well. I did want to talk about monitoring recommendations. So again, this is from the international guidelines that came out in 2017. This is the recommendation for checking that red blood cell galactose 1 phosphate in blood. They're suggesting you do it at diagnosis for sure. 3 months, 9 months, yearly after that until there's a baseline that has been established for your child or yourself. Some people will have higher galactose 1 phosphate levels and they just run higher, like 4, even 5 milligrams per deciliter. Other people might run in like 2 milligrams per deciliter. So everybody seems to have their own baseline. And so once you hit that baseline of, and you know kind of what it is, they're not emphasizing measuring that red blood cell galactose 1 phosphate as much as they used to. Studies have shown that there's little correlation between those galactose 1 phosphate concentrations and those long-term clinical outcomes that I talked about. So again, I would say clinics are not measuring this as often. Again, once it's stabilized. It may have a value if you're trying some of these foods for the first time that might be on that moderation list. You can check it, the Gal-1P, before you start that food, then eat it for a few days, check the Gal-1P again. If you're seeing a big spike up, well, that might tell you that's probably not something you want to eat. But that's really about the most valuable part of measuring red blood cell Gal-1P after you've kind of established that baseline for each patient. About bone health. So patients with classical galactosemia are at risk for impaired bone health. The reasons why are the restriction in dietary intake. We get most of our calcium and vitamin D from dairy products, so we're taking those away. That increase the risk of problems with bone. Decreased physical activity in some patients, some just are not as active, and there is a correlation between activity and bone density. Certainly in females, the ovarian insufficiency can cause changes in the estrogen levels, and estrogen has a big role in calcifying bones. So if females are on hormones because their levels are low, then that reduces that risk. But if not, there is correlation between the females if they have low estrogen levels and are not treating it, and that increases the risk with poor bone mineralization. There's likely other factors that they're looking into, not 100% clear why this is happening, but certainly these patients are at risk. I just want to go through a little of the bone basics so you kind of have an idea of what's going on. So when bones are forming, the first thing that happens is you lay down collagen, and then that collagen is mineralized, meaning that calcium, phosphate, other minerals are adding into that collagen. And bone is, we don't really think of it as having metabolism, but it does. It's all at all points in time. We're forming bone, and the type of cell that does that is called osteoblasts. And then we're also breaking down bone, which is called resorption, and that's done by a certain type of cells called osteoclasts. So this is just kind of the bone cycle. Here you have over here these osteoclasts. What they're doing is they're demineralizing areas in the bone, forming this pit, I guess is a good way to describe it. And then the osteoblasts, those are the ones that mineralize bone, they will come into that hole in the bone and start mineralizing. This happens again all through the lifespan. The difference is that during growth, that formation by the osteoblasts exceeds that resorption by the osteoclasts. And that formation is greater up until you hit a point which is called peak bone mass. So you're gaining bone up to this point where you've got this peak bone mass. And then in most individuals, bone will start to be lost at a faster rate than it's being formed. So this peak bone mass, it varies for individual to individual, but it's usually achieved around age 35. It's influenced by exercise and nutrition. So we as dietitians really emphasize the fact that bone mass is really increasing in childhood, adolescence. That adolescent growth spurt is very important. And you need to have enough calcium, phosphorus, vitamin D at that point to put as much calcium into those bones so that when the resorption is greater than the formation, you have more of a store so that your bones stay stronger for longer after you kind of hit this peak bone mass. These concerns about bones, not all individuals with galactosemia will have poor or lower bone density. The way you pick this up is by DEXA scans. And that can show the mineralization level of bones. Some studies have also shown lower levels of different growth factors and enzymes that are related to bone formation and resorption. I just listed a few of them there. So again, some clinics will measure some of these enzymes or growth factors to kind of give an idea of how a person's bone calcification and bone density is. Again, DEXA tends to be the big thing that is measured. However, these growth factors, enzymes tend to be more on a research basis. So these are different risk factors. Again, that's hormone differences, more in females than males. Another concern is that there might be some collagen formation might be somewhat abnormal in classical galactosemia. There is an enzyme that contains galactose that is part of the collagen formation process. So that might be a factor. Certainly inadequate calcium intake. Studies have shown that about 75% of patients with classical galactosemia have lower calcium intake than recommendations. And then also lower vitamin D blood levels is also a risk factor. So there are a lot of dietary factors related to bone development. The big ones are calcium, phosphorus, and vitamin D. There's others as well. Phosphorus is very, very rarely deficient in the general population and in those with classical galactosemia. We get plenty of it in our diet. It's more our concern about calcium and vitamin D. And I'll talk a little bit about both of those. So this just lists the requirements for calcium. at different ages, and you'll see this big increase during adolescent years, 9 to 18 years. It bumps up to 1,300 milligrams per day. It's in the general population, most adolescents don't get this much. And without really paying attention to calcium intake, those with classical galactosemia would not get that high unless they're emphasizing foods containing calcium or using a supplement. So that's the age group that I really hammer that you need enough calcium to mineralize your bones before you hit that peak bone mass. These are just some foods that have calcium that you can use. Again, most of the dairy products aren't allowed, but the cheeses certainly would be. So that would be something you could eat. There's also some of the cereals are fortified with calcium. Many of the plant-based milks, so soy milk, almond milk, all of those plant-based milks, now most of them are fortified with calcium. Tofu is something, or some of those other soy products would have some calcium. Orange juice or other juices, I've noticed, have also started adding calcium and fortifying. And salmon, another fish tends to have some calcium because of the bones. There's calcium in leafy greens, so kale, et cetera, et cetera. It's slower than these other foods that are listed. It's also less available, so less calcium is absorbed from those different leafy greens, but certainly it can be used as a food source for calcium. If you do need calcium supplements, there's two forms: calcium citrate, calcium carbonate. Probably the biggest difference for our population is the size of the pill. Calcium carbonate can be big pills, hard to swallow, versus the citrate, which tend to be smaller size. Some things about taking calcium supplements. Divide the dose during the day. So anything 600 milligrams or less is going to be absorbed better than if you're taking 1,000 milligrams at one time. The absorption is not going to be as good. Looking for lactose extenders in these products. Any vegan calcium supplements that are out there, those would be dairy-free and okay. And then supplements that are made from bone meal, oyster shells, dolomite might have some contaminants. And so usually we recommend trying to stay away from supplements with those. This just lists vitamin D requirements. Tends to be pretty steady for children and adults. These are some food sources. Cod liver oil. Before I was born, everybody took cod liver oil in the morning. And one of the reasons why is they got vitamin D from it. But some sources include fish products will have some vitamin D, fortified soy milk, or other fortified plant-based milks. Most of the plant-based milks, very few of them, a lot of them include calcium, very few of them include vitamin D. So if you want one with both, you really need to look at the labels of these plant-based milks, because very seldom do they contain any vitamin D, but there are some that are out there that are okay. Just monitoring recommendations for vitamin D. This is something that we do yearly in all our patients, and it doesn't matter how old they are. We will monitor, it's called 25 hydroxy vitamin D. And this is the circulating form of vitamin D that's in the blood. So you're measuring how much vitamin D is in the blood that can be used by the kidney to make those vitamin D hormones that are used in bone processes. Depending on the lab, these are values that we use here at OHSU. If we are finding somebody with low vitamin D and living in Portland where it's cloudy, I honestly see a lot of low vitamin D levels, even when somebody is supplementing. So we really look at this. Some ways to treat it initially would be to give like 2,000 IUs of vitamin D, build the dose back up, and then put them on a maintenance dose, which is listed here. Some physicians with, kids who have very low vitamin D, I'm talking like single digits, will put them on very high dose vitamin D for like 6 to 8 weeks. That gets the vitamin D level back up, and then they can be put on this maintenance dose. So this is, in my opinion, very important to measure vitamin D. Again, we're pretty susceptible to vitamin D deficiency depending on where you live, but also like sunscreen, etc., decreases the production of vitamin D in skin. So that's also a consideration. You can have fine calcium and vitamin D supplements, so both of them are in there. And that might be the way to go. Your dietitian can help you decide which one you need and how much you need. But this is just kind of some examples. There are chewables, there are gummies out there that have both calcium and vitamin D. So it's pretty easy to supplement if you need to have a supplement. Just really quick, a little bit about DEXA scans. So the guidelines suggest doing a first scan before puberty starts. So depending on the child, that might be around age 10 to 12 years. If the DEXA scan is okay at that age, they suggest not repeating it until the child is through puberty and then check it again. During puberty, everything is changing. You're going to get different results out of a DEXA scan. So the recommendation is check it before, and then if things look okay, wait until after puberty to do it again. This is in Z-scores, which means it's age matched. So your child's scan will be compared to other kids of the same age. Because I think we're kind of low on time, I won't go through how they do the DEXA scans, but happy to answer any questions about that if you do. And then the last thing I want to bring up is the importance of exercise. So that weight bearing, that process of, having walking or running or weightlifting, any of these things can improve mineralization of the bones. So if your child is more active, that does help increase that peak bone mass. It does improve mineralization of bone, so I really encourage this. And it also plays a role in older individuals, slows down the loss of calcium and phosphorus from bones that are already developed. And again, so it's supporting the maintenance of bone mass later in life. Just a few references. My guess is I would say all clinics know about the international guidelines. It talks about diet, but also medical issues, monitoring. So certainly this is a reference. If you want to spend a lot of time reading, you also can look at these as well. And then we do have some resources that are available for parents and patients. These first three on this side can be ordered from Colorado. And I'll make sure that you get the site to order those. There's also one that's been put out by Jaguar Gene Therapy. So these are, again, educational materials available for parents and patients, and they're very well written. And so that's what I have. Thank you, Galactosemia Foundation, for inviting me to present. And looks like we have a little time for some more questions.
We do still have, yeah, we have lots of questions, so let's go. So kind of, I have to go through these because you've answered a lot of the questions. So I'm just trying to figure out which ones.
Okay.
So here's one. So somebody said that they were told that the body cell does make our own galactose. The highest levels are when we are a baby through elementary age. Is this not correct?
Again, it's not that the body is creating galactose. It's that we have that galactose. It's used in so many different processes with enzymes, etc., in the body. So everybody has that endogenous galactose production, but to me that word is deceptive because we're not making it. It's coming, from the diet, is coming from turnover of all those different processes, and that's what's keeping that galactose 1-phosphate elevated in the blood. Even though you or your child is on diet, you're still going to have a high galactose 1-phosphate, and that is because of that constant turnover, and the fact that you can't break it down as quickly as somebody without classical galactosemia. So the amount of galactose production or galactose turnover per body weight is highest in infants compared to adults. The older you get, the that level per kilogram of body weight decreases. But as the amount of galactose formation and that turnover is higher in adults. So adults might have like 1,000 milligrams of this endogenous galactose production, whereas infants, it might be something like 250 milligrams. But if you're going by body weight, it is higher in infants than it is in older individuals.
One question is to clarify, any Parmesan cheese and Swiss cheese is acceptable.
Yes. So Parmesan, the bricks are okay. Also, we check galactose in the shaking Parmesan, and that's very, very low. So yes, any Parmesan is okay. The definition of Parmesan is that it's aged quite a long period of time, and so it really does have very little galactose.
All right. Somebody is asking about the different types of galactosemia and sorry, the comments are jumping. So should the difference between the different types should all follow the same guideline?
No. The incidence of like the kinase deficiency and the epimerase deficiency is very low compared to that GALT deficiency. But when we do pick them up, and those forms can be picked up by newborn screening, we initially do this diet, and most of them will be on a similar type of diet. It may not be exactly the same as what we do with classical galactosemia, but certainly initially we do a diet in all forms of galactosemia. Again, there might be some differences, especially later on, but at least initially we would would have them on the diet and would use very similar recommendations as we do with classical galactosemia.
So, don't know if, well, this question is, take galactosemia has the same impacts on bone as classic galactosemia? Question mark.
Um, these are good questions, by the way, people. Um, it can. Again, probably less of an issue in those with variant galactosemia just because they, in their diet, they can tend to be more liberal and just have foods that have more calcium and galactosemia than the classical group does. But you still need to monitor, make sure they're taking enough calcium and phosphorus and all those other things. If they aren't, then I would say they're at risk for bone problems. Again, variants tend to have less restrictions, so it's probably less of a concern, but you still want to pay attention to the calcium and vitamin D and diet and, hormone levels, etc. In really all that variants or classical forms of galactosemia.
All right. So next question is, you mentioned that whey and casein on the ingredient list is okay if low on the list. So how do you draw the line between what is okay and not okay on the ingredient list?
Okay, I'm going to go back here. So whey, if you're seeing whey in an ingredient list, that is going to have lactose, and I'd be pretty cautious with it. If you have an adult, it's probably not as big of a thing if you're eating something that contains whey. If you're seeing casein or if you're seeing caseinates, those, and you're seeing them in the ingredient list, I would not be concerned about those because we're now allowing the casein and the caseinates. We're still cautious about the whey protein, and especially if your child is younger. If I'm seeing whey on a label, I would not give that to my child. If you got an adult, again, it is probably less of a concern and would be probably, fine to have it. But with
Whey as well.
I would be concerned and want to avoid that whey for younger kids for sure.
So Alexis says, why is it okay for adults but not kids?
We're just finding that adults they seem to develop, they're going to have these long-term complications. It seems to happen when they're younger. And they can still be present in adulthood, but they don't seem to get worse. So there are studies that compare adults with the complications, and really it doesn't seem that those complications are that progressive, or meaning getting worse in adults. So that's the reason we say that, being a little bit looser on the diet for an adult is probably fine. Would I say you don't have to be on diet? No, I wouldn't say that. But some of these, again, if you've seen wave solids far down on a ingredient list, I think you can be less cautious when you're an adult.
Here's enough. Well, there's lots, but how about Irish matured cheese, which I don't even know what that is, or other aged cheeses not mentioned on the list? So I guess, how do cheeses end up getting on the list? How do they get chosen to be tested?
So we took the most common ones That's how we came up with our list. The group out of England, um, the London group, is still analyzing different kinds of cheeses, and they have lists like that include somebody Dom or Gouda cheese, etc. Some of these cheeses that we tend not to eat as much. Um, they have measured a lot of different cheeses than what we have listed here. And I think, going to the website for the group out of Europe, and at the top of my head, I can't think of what it is, Galnet, I believe. Um, they certainly have more cheeses that they've analyzed. So we want some kind of numbers before we're putting something on the okay list. And again, the number of cheeses that have been measured in the Europe group is much greater. So I would suggest looking there. A lot of them are cheeses that would be harder to find here in the States, I think. But certainly the list is more extensive than what I've listed. Again, we just chose what would be most likely to be eaten here in the States. But there are other European cheeses that you probably can find here that are probably fine. But I would use the lists that come out of um, the London group.
I think this one is, what age should you start giving a child vitamins?
Oh, okay.
So, changing
It
gears a little.
Yeah, it really depends on formula intake. So if you have your child is staying on a soy formula for longer than a year, and they're taking it really well, they likely don't need extra calcium. They likely might not need extra vitamin D until the intake of those formulas decrease. So it's more of and the reason I'm saying those formulas because they contain all vitamins and minerals. That's just the definition of a formula. So it really kind of depends on how much your child is taking. I would say I typically see formula intake decrease after age 1. And so you want your dietitian to add up how much calcium, vitamin D, other nutrients that your child is getting, and they can, give you an idea if you do need to start a supplement or not. But most of it is depends on how much formula or other foods that your child is eating. I mean, we have some that really don't need extra calcium because they eat a lot of tofu or they're, eating a lot of those cheeses. And when you add it up, it's sufficient. Um, Vitamin D is a little bit different. And, we tend to pretty much always supplement that after a child stops taking as much formula. So it's really more what they're eating rather than a certain age. And again, that's what you want your dietitian to help you out with, because they'll add it up and tell you. I will say adolescence, it's really hard. It's hard for all of us in that it's adolescent years to hit that calcium recommendation, especially girls. And I'm just talking general population. We just do not get enough calcium. So during that time, most of them are on a calcium supplement. Almost all of them are on a vitamin D supplement, again, just to hit that number to assure you're getting enough for good, calcification of the bones.
Well, I think that you've answered a lot of questions. I know that there are a lot of questions in the chat that don't have to do with diet, and we will hopefully we're going to have lots of webinars in the future, and hopefully we will be able to address all the different types of questions. Again, I would like to thank you, Dr. Sandy, for giving us your time and your knowledge. And yeah, we were really excited to have you here. So
Okay.
which is
Yeah, that's a lot of fun. And I'm glad people hopefully enjoyed it. And again, I'm happy to answer diet questions. So I'm just going to give you my email. You're welcome to send me questions. It's well, actually, maybe Nicole, you can put it out someplace, and then they'll have it. If I start to spell it out, it's just going to get kind of confusing. So, but you know, questions I'm happy to try and answer. Sometimes I don't do it right away because lots of other stuff, but I'm happy to answer some whatever it is that I can about the diet.